How are we doing? Great. So you're all welcome to another antenatal class session organized by the Joje Center for Women's Health. This picture is very fine now. The pregnant women, how many of you plan to take pictures, antenatal pictures during your pregnancy? See, all of you who have waited for a long time, you must take pictures. And I'm sure you are aware we have a studio. We have Joje Studio, where you can take pictures, very fine pictures, so that you can shame the devil. So that you can use it to do shakara. So that's why it's very important. So, you know, when you are pregnant and when you're not pregnant, they're two different things. So you see how you were looking, how beautiful you were when you were pregnant. So you can show your baby. Say, see, this was how mommy was looking when mommy was pregnant. All right? So if you need to have those services, you can get in touch with. Okay, so today what we're going to be doing is to acquaint us with the general antenatal process, okay, as we have it here. All right, we'll just really run through what we normally do when we say you're coming for antenatal clinic, you're coming for antenatal care, so that when it is not done, so at least so that we're able to raise your expectation, most importantly, that at every stage, this is what you are supposed to do. All right. So when you come in, you are assured that you have that assurance that you are being taken care of properly. Okay. Next slide. Now, the Joje Center for Women's Health, what we are promising is that we're going to provide you with excellent antenatal care services. All right. And why are we doing this? We're doing this to ensure the safety of your pregnancy and to guarantee a good outcome. Because at the end of the day, what is important for us is that a pregnant woman is able to deliver a healthy baby or babies, and that herself is also healthy. It is good when a woman gets pregnant. Oh, we are celebrating. Oh, we are so happy. But the real joy, well, let me not put the real joy. Let me say that the joy is perfected or completed on the day she delivers. Because it's not every woman who gets pregnant that goes on to deliver. There are women who get pregnant and they will lose the pregnancy in the very early stage. In fact, there are some, when they are confirmed pregnant, 2 weeks after, when they do the pregnancy test, there's nothing inside the womb. It's a chemical pregnancy. There are some that will have something in the womb, but in the first trimester, in the first 3 months, they will have a miscarriage. Unfortunately, there are some who will go on in the second trimester, they will lose the baby. There are some in the third trimester. The one that is most painful is the one that gets all the way to 9 months. Just few days to delivery, and then the most tragic thing will happen, and then the mother gives birth, a stillbirth. The worst of all, which we try to make sure it doesn't happen under no condition, is the loss of the woman. In Nigeria, out of 100,000 women who go through pregnancy, we are still recording up to 800 women that die during the process of childbirth. The good news is that for us in this center, since inception, we've never recorded anyone. And that is why good antenatal care is important. And so what we are offering and prioritizing is that we have a healthy mother and that we have healthy babies. Okay? And we have zero tolerance for maternal morbidity and mortality. What does that mean? It means that a woman, while she's pregnant, should not lose her life, and there should be no life-threatening complications. All right? And so we do this by providing both personal and individualized care, because we recognize that, yes, all the women are pregnant, but they still have, some are high risk, some are low risk, some are more high risk than others. So during your antenatal care, we're able to identify we're able to categorize the patients into their various risk factors. All right, into their various risk factors. And so based on that, we're able to provide care. And who provides this care? It's a team made up of doctors, specialists, made up of nurses, all right? And both obstetricians, gynecologists, neonatologists, the midwives, we all work as a team to ensure that at the end of the day, a couple, they go home with their baby or babies. But to achieve all of this, we believe that health education is important. Because when a woman is informed about the process and about how the complications that may result, she's able to cooperate and assist the team to provide a better care. All right? So what are the core activities? Next slide. So the core activities provided by, in terms of the antenatal care, will include your antenatal clinic visit. And that is the one that you come to the hospital where you visit and you meet with the doctor. That is different from the class. This is the antenatal class. So you will have both the antenatal clinic and then the postnatal clinic. After you have delivered, you still need to come for checkups, just to be sure you're fine. A woman who delivers is not okay. She's still considered pregnant until 6 weeks after delivery. Afternoon. And that is if you are carrying one. If you are carrying two, you are still considered pregnant until 3 months after delivery. Because if you are carrying three, you extend it by some months. Why? Because there are certain issues that may arise after you have delivered. For example, a woman may be developing high blood pressure for the first time after she has delivered. All through antenatal care, there was no blood pressure issue. And then suddenly she has delivered. You don't just think, oh, everything is fine, go home. No. Some may just develop high blood pressure for the first time. Some people may develop depression. Why? Because they're not able to cope with the care of the baby. For some reasons, they are not coping. The environment, the coping mechanism, and all of those supports that are needed to help a woman navigate through that process is not there. And then suddenly, what should become a thing of joy now is now saddled with a lot of, challenges. So part of the care that is provided by the Joje Center for Women's Health, as it has to do with your complete care package, obstetric care package includes both the antenatal and then the postnatal clinic visits and then the antenatal class. Of course, we also include the intrapartum care, and that has to do with your delivery itself. All right? Because every woman who is pregnant must deliver. And it is that process of delivery that brings about the results, the outcome. Yes, there are some people that say they carry pregnancy for 2 years, 3 years. I don't understand how that will happen. So, well, for us who go to church, we hear testimonies and they'll say, I carried pregnancy for 4 years. And then finally, medically, that doesn't look possible, because a baby cannot stay for more than 10 months. If baby stays more than 10 months, things will begin to happen. The placenta will begin to fail, and that baby will not survive. All right? But anyways, once a woman gets pregnant, part of the job of the caregiver is to ensure that we take you through that process of pregnancy, successful delivery, and a postnatal care to ensure that you have a good outcome. Okay? So, having said that, next slide. When does this process of care begins? When does this care begin? So usually we advise patients to register for antenatal care after the second missed period. Okay, after the second missed period, which is about 8 to 10 weeks. That is when patients register for antenatal care, and it's based on appointment. And thereafter, the first antenatal clinic visit is called a booking clinic visit. All right? And thereafter, you'll be seen every 3 to 4 weeks until you're 28 weeks, and then every 2 weeks until you're 36 weeks, and then every week until delivery. So that is basically what the schedule is. But this is usually, next slide, this is usually for, okay, yeah, we are there. This is usually for the general patients. When I mean general patient, I mean the patients who you got pregnant spontaneously. And we tell you that, okay, after the second missed period, come in and register so that we can do your scan, confirm, and then you can start the clinic. But majority of our patients here who are sitting with me here, or those who are online, most of them got pregnant through IVF. And so if you got pregnant through IVF, when do you actually start your antenatal clinic visit? But the antenatal care actually starts the day you are confirmed pregnant. All right? Because after you are confirmed pregnant, you start your luteal support. That luteal support is part of the antenatal care. All right? But officially, we usually would say that you're registering for antenatal after you are done with the luteal support, which is 13 weeks. Okay? So after 13 weeks, you register for your antenatal. And why do we do that? Or why do we say after your second missed period? And that's because we want to make sure that you have gone through that first trimester. We have been able to, we are assured that your pregnancy is progressing well, and that the likelihood of having a miscarriage would have been reduced. There are some people who would want to come in for antenatal even far into the second trimester, but we usually advise, of course, for our patients who have waited and got pregnant through IVF, the earlier you start your antenatal, the better. So once you are done with your luteal support, because during your luteal support, you will be seen every 2 weeks. You will have your scan done, you're taking your medication, you are monitoring the baby's growth and well-being. So once you are done with that, then you can now register for your antenatal. At that same time that you're registering for your antenatal, you'd have had your cervical circlage done. I mentioned cervical circlage the last antenatal care, and I told you what it was. We will still be able to talk about the cervical circlage in more details during one of our lectures when we'll be looking at cervical incompetence. But after you are done with your luteal support, I'm sure we all know what luteal support is, right? Yeah. So after you're done with your luteal support, then you have your cervical circlage, and after your cervical circlage, You're coming up, you'll be seen in 1 week after that. And then at that visit is when you're supposed to register for antenatal. And if you decided you're going to do your antenatal with us, at that point is when some patients may decide to go to have the antenatal done in other facilities. For those who are not based in Abuja, they will do the antenatal in their home state or home country. For those who are in Abuja who decide they want to use other facilities, we are completely open to it. Okay? The choice of where you use for your antenatal is entirely yours. But for those who decide to continue with their program with us, you officially will register for your antenatal after you're done with your cervical cerclage. Next slide. Now, who do you see during your antenatal care? All right. Now, it's a team that provides your care at the Joje Center for Women's Health. You have the team of doctors and the team of nurses. All right. You have obstetricians, you have neonatologists, you have anesthesiologists. All right, I've already mentioned you have medical officers or residents, and then you have midwives. At different times during your care, some of these people will come in and play their role. Next slide. So during your first antenatal clinic visit, you book to see the doctor or the nurse. Now, when you come in, the first thing they're going to require you to do is to do your vital signs. And I said it is very mandatory. We'll go into details to look at each of the vital signs and what they represent. And then you have a proper medical documentation. Now, for those who got pregnant, who did IVF and got pregnant with us, you would realize that we don't do this number 3 after you have gotten pregnant, taking history from you anymore, because we already have your history. Okay? When you came in to register for your fertility program, we took a detailed history from you. So we already have that. And then the reason why sometimes we also will not ask you to repeat, to go to the lab and do your lab test, is because some of the tests you are going to be doing, we already have done them before while you were preparing for your IVF program. Things like your blood group, your genotype, we know them already. Things like your serology, tests for hepatitis B and C, syphilis and HIV, we have done all of that. Okay? And except, of course, if it's been more than 6 months that we did those tests, then we may require you to repeat the serology. All right? The other thing that we will ask you to do is your full blood counts. And again, that you also would have done when you were doing your cervical cerclage. So by the time we are seeing you and you're registering for antenatal, a lot of these routine tests you would have done. However, if you are considered a high risk, there are other tests we may require you to do. For example, if we consider you have a risk of developing gestational diabetes, then we will ask you to do a fasting blood sugar and 2 hours postprandial. If you are rhesus negative, your blood type is the rhesus negative. If you have not done the Combs test before, then we will ask you to do the Combs test once you register for antenatal. And of course, when you do your normal vitals and we see any abnormalities, for example, in your urine, if there is glucose, if there is protein, if there is nitrite, if there's leukocytes, we'll come to that very shortly. Then we may need to do some further investigations. And then you will now be asked to start your medications. Now, for all women going through antenatal, there are certain routine medications that you are placed on. Some medications because of the circlage that you have done. And some other medications, not just because of the circlage, but because of the fact that we want to reduce infection that could lead to your water breaking on time. And then you will see that the routine, for those of you who are currently pregnant, of course, you are all pregnant here, and you have done your cervical circlage, you realize that you are both on hematinics, that is either pregnant care or ferritin, you're on anti-malaria, which is very important. What we give you is paludrin, which you take daily to prevent you from having malaria. Or if you do have malaria, to reduce the severity and the frequency. And then you are also on salbutamol. The salbutamol we give to you is to make your womb reduce the threshold for contractions, because we don't want you to have any contractions at all. And also because of the fact that you have a cervical circlage on, the tendency for your uterus to become irritable is there. So we just place you on that to reduce that. And because you have a circlage on, we also will place you on an insert. It's Clovina, which contains both bacteria and antifungal. That is to prevent infection in your vagina, okay, from occurring, because that can predispose to your water getting broken before time. And then of course you're on aspirin. Aspirin is because we want to make your blood thin, reduce the chance of you forming clots, because pregnancy on its own can predispose to having clots. And the hormones you were taking to conceive, and which you continued throughout during your luteal support phase, all of those things can help to make your blood a bit thicker. So we place you on aspirin to make sure your blood is thin, flows well, and prevents clot from forming. So those are the medications that you will be placed on. Any other medication you are placed on will not be individualized, either because of a particular challenge that was found. Okay, maybe you have ulcer, we place you on omeprazole or gestating suspension, or maybe there is an infection, we place you on antibiotics, or we want to treat for malaria because you now have malaria. We're not just preventing now, we want to treat, and then we'll give you treatment for malaria. All right? But those are the routine medications that you will be on. Next slide. Now, for vital signs during antenatal, every patient who is coming for antenatal care, it is mandatory that you do your vital signs. And this is done before you see your doctor or midwife. And then once you're visiting your doctor, ask about, my vital signs, are they okay? All right? And then the vital signs that is done must be documented. So we'll quickly just go through what the vital signs are. Next slide. So the vital signs that are done, the 5 of them, your blood group, your blood pressure, no blood group, your blood pressure, your pulse, respiratory rate, your oxygen saturation, and then your temperature. So it's not just 5. Next slide. The other things that are checked. We check your weight, your height, and the checking of the weight and height will give you your body mass index. And then we also do urinalysis. So these are the parameters that are checked. So quickly, we'll just go through each of them. Next slide. Blood pressure. Your blood pressure is, in fact, antenatal, one of the important things that antenatal care helps to do is to be able to detect increase in blood pressure. One of the commonest cause of maternal deaths in Nigeria is due to hypertensive disorders in pregnancy. You have bleeding, that's hemorrhage. The next one is hypertensive disorders. There are women whose blood pressure has never gone up before. They've never been hypertensive. But suddenly, as soon as they got pregnant, particularly after the 20th week of pregnancy, their blood pressure begins to go up. If it is not detected and treatment started to try and control the blood pressure, it can deteriorate to preeclampsia and eclampsia. So when you hear that a woman fitted or had convulsion during pregnancy, it was because of undetected high blood pressure, and it can kill. And so what we do is that's why each time you come to the clinic for your visit, make sure they check your blood pressure. Very important. Very important. If you come to the clinic every day, something brought you to the clinic and you have to come and see doctor, you must check your blood pressure. It is that important. Because the only way we can pick up a rising blood pressure is when you do your blood pressure check. And so once we do your blood pressure check, we will document it, and then we can easily tell by the time we look at it over the months, oh, this woman's blood pressure has been consistently like this. Suddenly, things just went up. What happened? All right? So it is very important. And when do you check your blood pressure? Once you come into the clinic, you come into the reception, and then you see that you don't just come in and just walk straight to the nursing station. Oh, yeah, how na day? Please check my blood pressure. I've come. No. If you do like that, we'll not get a good reading, because you're just coming out. Even if you came in with your car, you walked from the car park into the reception. So when you come in, the first thing to do is to sit down for about 10 minutes, relax, be watching Africa Magic on the TV or CNN. Just relax. Then 10 minutes after, on pause, you can now go in and then have your vital signs checked. All right? So you will notice that they will generally use the digital or the manual. First the digital. If they think that, oh, this blood pressure, they want to confirm, then they can use the manual to check it. All right? They usually will use the left arm because it's closer to the heart. Gives you more accurate reading, but you can either use the left or the right. All right? Now, what is considered as normal blood pressure? You know, there are two blood pressure readings, the upper one and the lower one. The upper one is called the systolic blood pressure, and the lower one is called the diastolic blood pressure. Anything less than 140 is okay. It's considered normal for the upper one, that is the systolic blood pressure. And anything less than 90 for the diastolic is normal. Once it gets to 140 over 90, then that is abnormal. All right? And so that is the threshold. You've just hit the borderline. And so we now start watching and asking ourselves, okay, is this woman trying to develop pregnancy-induced hypertension? We want to find out what has your blood pressure been before. It's also possible that there are women who are already chronic hypertensives. But there are two categories of patients. You have those who have never been hypertensive, and it is just in pregnancy that we are picking up the fact that their blood pressure is hitting that mark. And then there are those who are known hypertensives who are already on medication. And then they are now pregnant, and the pregnancy is now worsening the hypertension that they have. They are now not able to have good control. So either of them, the goal is to make sure that we stabilize your blood pressure and take you as far as possible to when the baby will be fine to be delivered, and then we'll deliver you. It's important to note that for women who develop hypertension for the first time, it's the pregnancy that is causing the hypertension. And the only way you can actually be free and the blood pressure would come down is after you have been delivered. The medications that are given to you are to just control it, to bring it down a bit, to stabilize it to such a level where you can manage till the time of delivery. So once they take your blood pressure and you're seeing 140/90, don't panic. They come in. Because when you panic, you think will just further go up. But I've now said, MD said 140/90. Hey, there's trouble. There's no trouble. Just relax. Okay? But it's important for us to note that it's 140/90. Now, there are some people who are already hypertensive, and then when they come in, we ask them, have you been taking your medication? Some would say, oh, I forgot. I didn't take it this morning. Oh, even yesterday, I forgot to take it, because poor compliance can also be the reason why the blood pressure will go up. All right? And for those who have never experienced blood pressure before, we will take note of that. If it's just the first time we are getting that reading, we will not start you off on antihypertensives immediately, particularly if it's just a borderline, we are getting 140/90. What we will do, we will ask you we'll ask you about your activity for that week. Were you stressed up? Was there anything that you were involved in that could have made your blood pressure go up? Are you sleeping well? Some will say, oh, I've not been able to sleep well. I had this. Okay. You can give them sleeping medication to make them relax and sleep. And once they take that, blood pressure will just come down to normal. All right? And so we will do that. And then when you come again for your next antenatal visit, we would now check the blood pressure. Next slide. Now, between the systolic and diastolic, which of them is more important? Which of them is more valuable to us? Is the lower one. So if I see a woman who has a blood pressure of 150/80, I won't be worried, because the lower one is normal, the upper one is high. Because that upper one, so many things can make it go up. Just worrying about money alone can make your systolic to go up. That God did not give you enough money. This baby is coming. I've not bought things for the baby. What is this now? You understand? That alone can make your blood pressure to go up. All right? Or you went through any amount of stress at all, it can make it go up. But the one that can affect the pregnancy, that can be a challenge, is the lower one. Okay, it's the lower one. So if the lower one goes up a bit, then we'll have to pay more attention to it. Now, there are patients who have not high now, but low. Say, blood pressure is 50, systolic is 80/90. Maybe your blood pressure normally was maybe 120/80, 110/70, and then you're now pregnant, and you're now getting systolic. They did your blood pressure, the nurse told you your blood pressure is 80/50. I'm finished. No, you're not finished. You're perfectly fine. Because when you are pregnant, there can be an increased resistance or reduced resistance. So your blood pressure can actually drop. As long as there is nothing that has happened that could warrant your blood pressure going down. For example, you've not been stooling. If you've been stooling and vomiting and you are losing fluid, then we can say, oh, that's the reason why your blood pressure is low. Or if you're on medications that can lower blood pressure, we say, oh, this is the reason why your blood pressure is low. But if nothing of such is happening and you're not dizzy, you're perfectly fine, even if you have a blood pressure of 80/50, it's okay. We just know that it is due to the low resistance that is now present that has made your blood pressure to remain like that. And anyway, there are people who naturally have low blood pressure. There are people who work normally, even before they were pregnant, their blood pressure was 90/60, 80/60, and they were perfectly fine. So it's important for you to also know what your pre-pregnancy blood pressure is, so that we also use that to compare. All right. All right, so this is the pulse. Apart from the blood pressure, we also want to measure the pulse rate. The pulse rate is between 60 to 100 beats per minute. That's pulse. That's when they do here. They put your this in, it can measure all of those things. The pulse tells us how fast your heart is beating, how fast it's pumping blood. There are certain factors that can make your pulse to be high, and certain things will make your pulse to go down. So if your pulse is above 100, we call that tachycardia. And if the pulse is below 60, we call that bradycardia. All right? Naturally, when a woman is pregnant, her pulse goes up. So you will notice that when they do your pulse, they'll tell you your pulse is above 100. Nothing to worry about so much. Except if, of course, it's now giving you, some challenges. All right? The medication you are using, the salbutamol, can also increase your pulse. So you need to know that. So pregnancy plus salbutamol, your pulse will be a bit high. But if your pulse is high and then you are getting exhausted frequently, you walk from here to the reception and then you already try to catch your breath, or you climb stairs, you climb these stairs. By the time you get to the top of the steps, you have to sit down first to rest. Then we need to go further and check. It's possible you could be anemic, in which case your Paxil volume is low. It's possible there could be a cardiac problem. It's not just the normal pregnancy that is the issue. All right. So that's that. So we want to find out what drugs you're taking. I just mentioned one of the drugs that can increase your pulse. Of course, if you have a fever, that can also increase your pulse. Okay, next slide. Then respiration, we'll check your next. Then we'll check your respiratory rate. Your respiratory rate is usually between 18 and 22. All right? But sometimes the respiratory rate can be high when you are pregnant. All right? But when it's very high, it could indicate that there could be some respiratory challenges. Now, apart from the fact that your respiration is high, you're having difficulty breathing. That means that you have a challenge in your chest. All right, so that's the reason why we do this vitals. So once we do the vitals and we see that these parameters are abnormal, we now begin to ask questions. We want to now find out, could there be a challenge? We'll now start asking you, are you having cough? Do you have chest pain? Why? Because we already have picked up a signal and the pulse in the respiratory rate. And so we want to find out if there is something else that is causing that. So pneumonia, upper respiratory tract infections, all of those things are things that can sometimes increase your respiratory rate. Like I said before, pregnancy on its own can also cause that. And it also depends on the number of babies you are carrying. A woman who is carrying more than one, sometimes her respiration will be more higher than the one who is carrying just one. All right, because why? Our tummy is bigger for age than the one who is carrying one. And because it's very big, sometimes the diaphragms are splintered. And so she is not able to breathe. The amount of air she can take in is less than the person who is carrying one. And because the person is not able to take in much air, he now finds himself breathing more frequently so that he can take in more air. And so that is why the respiratory rate would increase. So the other thing we also measure is, next slide, is your oxygen saturation. Because it's not just important for you to be breathing. You want to know what is the percentage of oxygen that is contained in your blood. Because remember, your baby requires oxygen. And so and that oxygen the baby requires is taken from the blood, your blood. And if the level of oxygen that is in your blood is low, it will also affect the baby. And what are those things that can make your oxygen low? If there's a challenge in your respiration, in the respiratory system, because that is where you have the exchange of oxygen going into the blood, all right? And so if that is happening, or if there is a reduction in the blood flow, or if there's a reduction in the oxygen carrying capacity, that is the packed cell volume that carries the oxygen, in which case you are anemic. All of these things can reflect in a low oxygen saturation. And once we pick that up, then we will need to intervene. So usually we say anything 90 and above is fine. Most of you, when you do your vitals, usually will record 80, 88, 98 to 100, which is good. Once it gets to 90 and below, then something is wrong. Okay? So even without you telling us anything, by just doing your vitals and analyzing your vital signs, we can tell if this pregnancy is challenged or not. All right? So the next vitals is your temperature. That one we must, I'm sure all of you, when you go for vitals, they do as if they want to shoot you. They bring this gun like this. What they are doing is they are taking your blood pressure. Those days they used to say, open your listener, put something inside and do like this. We don't do that these days. So we just point something and then it takes your temperature. Again, once your temperature is taken and it's up to 38, that means you are pyresic. And so there's fever. And we want to find out what is the cause of the fever. Is it malaria? Is it typhoid? Is it respiratory infection or UTI? All right. So temperature measurement is very, very important. So put them in they may not even know that their temperature is even high. They just come and just feel they feel unwell, but they don't know why they are feeling unwell. They just think, well, maybe it's just the pregnancy. But then they come in and they take their temperature. I say, what? Temperature is 38 point something. That alone means that there's something that is causing your temperature to rise. And so what will most likely happen is that the doctor will send you to the lab to run some tests, and based on the results of the tests, you will be treated. Okay? Then the next check is your weight. Very important. All pregnant women must ensure that they check their weight regularly. Why? Why is weight important? I mean, I did the weight the first time. Do I need to be checking my weight each time I come? Yes. Why? Because we want to know how you are gaining weight. Because we expect women, when they are pregnant, they should what? They should gain weight. So we will check your absolute weight. And then, of course, we'll have determined your height already. And then we'll determine what the BMI is. So we know what your weight is before you got pregnant. And then once you get pregnant, we'll now start monitoring your weight. We expect you to gain weight. Next slide. During the course of pregnancy, most women will gain between 12 and 15 kg of weight. Most of them, average. That is the amount of weight gain they would have. Again, this can vary depending on the number of babies you're carrying, all right? And then if you were already overweight, there's some people who are already overweight, who are already obese. When they get pregnant, they don't really gain so much because the body is already saying there's nothing to add to this thing, just maintain yourself. As long as baby is getting enough, it's good. But there are those who already are trying to, they need to gain weight. And they did not get pregnant. But they will say, finally, opportunity. And then they will gain. Some may lose weight and now gain the weight. Those who during the first trimester were not eating well, they were always vomiting because of hyperemesis gravidarum, they may lose a lot of weight. When they now, in the second trimester, they will now have to gain the weight they lost before, and then they now start gaining some. So if you see a woman before she got pregnant, and then you are seeing her in her second trimester, you say, you've not gained any weight at all. In fact, you've even lost weight. No, you want to find out in the first trimester, what was her weight? If she lost weight in the first trimester, and you are now seeing her in the second trimester, that she's still the same with what she was before she got pregnant, what has happened is that she has gained weight. She lost weight, and then she has now gained it back. And usually we expect that every week, an average of 0.5 kg or 500 grams should be the weight that a woman should gain. I know someone will be thinking that, doctor, MD, I'm not gaining weight too. Are you sure everything is fine? Be calming down. If you have not gained weight, we have to now ask, when we have to now monitor. That's why one weight measured or 2 weeks or 1 month is not enough. When each of these things we do, each time you come for your clinic visit, you do it. So when we want to interpret your weight, we have to look at the beginning. What was your weight before you even got pregnant? What was your weight after you got pregnant? What was your weight 3 months after? Just like that. And that's how we would calculate it and be able to determine if there's a challenge or not. But just to say that if you're not gaining weight in pregnancy, it's most times not a challenge to the baby. Why? Because the baby is a parasite. It's a parasite. The baby will feed from you, even the one that you don't, whatever is stored, it will take, it will break it down. Before baby will starve, you yourself, you would have starved to death for it to affect the baby. Do you understand? The baby will find a way. It will find a way. That means the starvation would have affected you as a person first so well before it will begin to affect the baby. So, no fear. All right? So, even if it's 5 kg, 7 kg, 8 kg you gain throughout, no problem. Because no matter that, some women who don't really gain weight, the way they were when they got pregnant. For even 7 months, you'll be wondering whether this woman is pregnant. Is she pregnant? She's just looking, nothing has changed. Even her tummy, just a little bit of small, this thing. Where is the pregnancy? And then, lo and behold, 9 months, she has delivered a baby big. Where was this baby? So women just have that kind of body. And then there are some, 3 months, the thing is showing everywhere. That tummy is, are you sure it's only one that's inside this tummy? Doctor says it's one, though. And tummy is this big. So every woman is different. Okay? And so the gain of weight will be different during the course of the pregnancy. But once a woman is gaining weight steadily, we are happy because it means that the baby is growing, the woman is also doing well. Because there are certain weights that must be added to your weight before you started. All right? And so the next vital signs is the height. This one, we just do it only once. So each time you come to the clinic, don't say, doctor, MD, they did not measure my height. Your height does not change. You don't get taller or shorter during pregnancy. It is the height you had when you started. That is the height you maintain until you finish. Okay? So and the reason why we determine your height is just to be able to measure your BMI. Next slide. To be able to measure your BMI. Because most times now, we we don't just look at the absolute weight anymore. We try to look at the body mass index, which is calculated based on the weight over the square of the height. So we're able to determine whether you have a normal weight, whether you are overweight, you are obese, morbid, or even if you are underweight. Okay? What we really want is for women to have a normal BMI. But I know that a lot of our women, they don't have normal BMI. Their BMIs are usually in the overweight and sometimes in the obese region. And there are obstetric significances to this. There are some complications that can occur for a woman who is obese and she's pregnant. And that is why we need to calculate these things, so that it also helps us to monitor and to prepare for such patients. All right. So normal. So what's your BMI? Do you know? Your BMI, do you know? No, sister. So we don't calculate BMI for our patients. They don't know what their BMI is. So if I ask you if you are normal, overweight, or obese, or morbid, no, none of it is morbidly obese. I can, by just my face, I can know whether you are morbidly obese or not. Whether you are obese, I may not be able to tell. Some people may be obese, but they may just look as if they're just overweight. So next time you come for the clinic, ask them, what is your BMI? Let them tell you what the BMI is. Okay, next. Then urinalysis, very important. When you come to the hospital, when you are coming, don't just pass urine before you start coming. Then when you come in, I say, sorry, I don't have urine. I just passed, I just peed before coming. We need the urine. We need the urine. From that urine test that we do that is so simple, there are a lot of things we can determine. We can determine if you have sugar, if you are developing gestational diabetes. We can determine if there's preeclampsia occurring as a result of high blood pressure, or if you have a renal disease or a urinary tract infection. We can also detect if you are not eating. The women that will just come and just say, Madam K, how far? What happened? You've not been eating. The one will be surprised. How did them know that I've not been eating? Because you have ketones. Like I said before, the baby is a parasite. So baby was not getting anything fresh, but baby needed to feed. So baby started breaking down the one that was stored in your body. And so when you come and we do your urinary test, your urinalysis, we will discover that there are ketones. Ketones are products of broken down fats. And once you have ketones, it means that you are not eating enough, you're not having enough calories, enough carbohydrates. So, but the baby is not getting enough. So it has to now tell the body to produce enough. And since the body is not getting enough, it will break the one that was stored. All right? And so we will see that. So what do we tell you to do? Eat more. So say, yes, honestly, I don't feel hungry these days. For a whole day, I can just go without feeling hungry. I'll just maybe just take one small meat pie. Pregnant woman, one small meat pie the whole day. Yes, now I don't feel hungry at all. You must feel hungry. Even if you don't feel hungry, you must eat. Why? Because of the baby. All right. So once we detect that there is high ketones because you're not eating, of course, women who have hyperemesis gravidarum, we know that one is a challenge in the first trimester. And once we do their urinalysis, we will see that ketone. What we do is that we will try and stop the vomiting. Because for these ones, they're not able to tolerate any food. Anything they take in comes out. So we admit such people, rehydrate them with infusion, give them medications to stop the vomiting. And then once they start eating, they do well. Okay? Then the other thing we can also detect, next slide, is if you have infection, nitrites. Once you see that nitrites in your urine, that could mean that you're having urinary tract infection. So we will ask you to do urine culture to be able to confirm if there is infection or not. And then once we see urobilinogen, it also could mean that your red blood cell is being broken down. So we say, oh, did you just have malaria? So, yes, I was sick. So, oh, we picked it up because your urine showed that there was a high level of urobilinogen, which are products of broken down red cells. And so what that means that it's possible that your pack cell volume may have dropped a bit. Or we can also pick out a lot of white blood cells, which could indicate there's infection. All right? And then the pH. So you can see that there's a lot of information that your vital signs give to us that you do. So if you ask me, the most important thing that is done during antenatal visit, clinic visit, is your vital signs. It's your vital signs. It's the interaction with the doctor is just to confirm, okay, everything is fine. You see that scan, we scan you every time you come. It's not absolutely necessary. In fact, the associations will belong to the normal standard. It's just that because we have scan and it is more reassuring because every patient wants to come and hear tick, 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 tick. Aha, okay, I'm okay now. Because if you come to hospital and we don't do that on you, the doctor, is everything fine? Say yes. Are you sure? The only way you can assure a woman that is pregnant that her baby is fine is that the woman hears what? The heartbeat. So next year we are thinking of introducing a program, Antenatal Clinic Online, where we will be able to offer antenatal care. You don't necessarily need to visit a clinic. Maybe you can only visit the clinic once or twice. Why? Once you're able to measure your blood pressure at home yourself, and you can do that urine test yourself and monitor your pulse. And they will give you something that can check your baby's heartbeat. It's finished. So for patients who are not based in Abuja, because part of the challenge I know that women have is going for antenatal clinic visit. It can be hassle. It can be very, very frustrating. A lot of time that is wasted. At the end of the day, what do you actually go there to check? And so we want to be able to empower our patients for them to be able to be part of the antenatal care. So that you only go to the hospital when you know that there's really something that is not okay. And then you just go once in each trimester just to have a scan done and see how your baby is doing. All right? And that way we're also able to keep in touch with our patients all over. All right, but I just said that to say that, see, these are the important things that are needed. So you come to the clinic and you don't do your vital signs, you have lost 60 to 70% of your visits. Because just to come and say, oh, you see doctor's face and you do scan and baby's heartbeat is there, that's all. No, it doesn't. If there's any challenge, we will not know. But it's a vital signs that you do that tells us that everything is fine. Even if you do all your vital signs and everything is fine, and you don't come and do a scan, there's no problem. As long as we can pick up your fetal heart rate, all is well. Okay? So, please, all patients, make sure you go for your vital signs. And no patient should come to the doctor's office if you have not completed your vital signs. Some will say, I don't have urine now. I can't do urinalysis. That one is very important. So when you know you're coming to the hospital, take some water, not too much, so that you don't feel too pressed. So some people will just come, as they are dropping their bag, the first place they are going to is the toilet. They'll say, no, I wish I knew. So just come, take some water as you are coming. I see the way they're drinking water now. Just drink small like that. And as you're coming to the hospital, you wait, you go for your vital signs, you pee, you check your urine, and then you can go and You can go and ease yourself. Okay? So, next slide. Like I said before, the first booking visit would visit where we do a detailed medical documentation. Except for a lot of us, because of the fact that we have done this when you started your fertility journey with us, we don't really bother to go through that process anymore. But just for you to know that during your antenatal, part of what we do, but kind of your first visit, is that we want to have details of your medical history, your biodata, obstetric history, gynae, and your medical history. From your biodata, your age speaks a lot. A woman that is 50 and a woman that is 30 that are both pregnant, they are not the same. How I'll be looking at the woman that is 50 and how I'll be looking at the woman that is 30, and the management protocol and the risk associated are different. And so that also tells me, I also want to also say here that when you are giving your dates, don't give your civil servant dates, age. For those of you that are civil servants. Because I've come to realize that more than 80% of all civil servants, their age are not correct. Why? Because they want to spend more time serving Nigeria than say retire and go and relax and be chilling. So they put another date. Once you come to the hospital, tell your doctor, give the right information. Okay? It's important. Because with that information is important throughout your care. Throughout your care. Because a woman that is getting pregnant for the very first time and she's above 35 is already considered a high risk. Because these are the ones that have the tendency to develop hypertension, diabetes. They are the ones that when they get pregnant, hyperemesis gravidarum will be plus, even though they are carrying one. You understand? So there are those who will need more attention on them. So just your age alone already can help us to classify where you belong. And part of that biodata that is also included is your parity, whether you have been pregnant before or not. A woman who has gotten pregnant before and delivered and is now coming to get pregnant for a second one is different from a woman who has never been pregnant before. Or a woman who has been pregnant, had termination or had a miscarriage, and has not carried a pregnancy to term and deliver. And so if we are dealing with a nulliparous woman or a multiparous patient, it's different. And so while I will classify a nulliparous patient, someone who has never delivered before as high risk, I will consider somebody who has delivered once low risk. Why? Because the body has gone through this process before. So it's not a new thing. Whatever unforeseen challenges that the woman would face, the body has gone through it. So the body is already accustomed to this process. So the woman is not likely to spring surprises. But a woman who is carrying pregnancy for the first time, the body is just seeing all of the changes and everything happening live for the first time. And you don't know how that woman would do. Okay? And so that's why in the obstetric history, we want to have details of your obstetric history. How many times have you been pregnant before? Have you been pregnant and delivered? How did you deliver? Was it through vaginal delivery or was it through CS? A woman who has delivered by CS and a woman who is now pregnant and who has never delivered by CS, who delivered by vagina, they are two different persons. When a woman is having contractions in the third trimester, and I look through her history and she has never had surgery, whether it's cesarean section or a previous mammectomy, the risk for that woman is less compared to a woman who has had the CS before or she has had mammectomy. So obstetric history, surgical history, gynae history, medical history, all of these are all very important. They help us to manage to manage the patient. All right? The gynae history. How many years of infertility? All babies are precious. So you know what? Right? All babies are precious, but there are more precious babies than others. A woman who waited for 1 year and got pregnant, and the woman who is getting pregnant for the first time after 30 years. They say they are babies, right? But you know that some, in the eye of the person, will be more precious. Because the woman who loses a pregnancy after 1 year, within 1 or 2 years, she should have conceived again. She doesn't have any issue. But the woman who waited for 30 years to get pregnant, and finally she's pregnant, God forbid, anything happens to that pregnancy, it will not be easy. And so that's why we look at all of these things to say, okay, everybody, irrespective of your risk, you all get optimal care. Do you understand? But what we're trying to do when we're looking at this history is to ask ourselves, this one, will it spring surprise? This one, is she likely to spring a surprise? It's better we know now and prepare than for us not to be aware and then, boom, she just springs a surprise and takes us unawares. That is why we say we promise both personalized and individualized care. And what helps us to do that is the detailed history that we would have taken. All right? And so when you're seeing for patients who come in for the very first time to start off the journey here, when we're taking you through that detailed history and asking you so many questions, please don't get offended. It's for your good. It helps us to care for you. Okay? And if there are other histories that we may not even have asked, volunteer it. Hey, doctor, you didn't ask me this one, but let me tell you. So I had this procedure. I don't know what it is, but this is what they did. Just let us have all the information about you. We will decide whether it's going to be helpful or not. All right, next slide. So I talked about surgical history, all the surgeries you've had, they will all be helpful. And then family and social history. Under this one, we want to find out whether you take small stout once in a while, or whether you do the big one, or whether you smoke. You know, we don't have a lot of, do women smoke in Nigeria? They smoke, Abi? It's not only in advanced countries. I know that if I even more women smoke than men. And those things are not helpful. If you take alcohol and you smoke, it will affect the baby. So these are some of the things we also want to counsel. We want to know what is your social history like, and then counsel you appropriately. And then also want to find out if there are any familiar disease, if there's any disease, any genetic disease in the family. Are your mom, is she diabetic? Is she hypertensive? You know, is there blood pressure issue? These are things that once we find out, okay, this woman, her mom is diabetic, okay, she could be a high risk for gestational diabetes. And so we need to get all of those details. And they also include drug. If you're on medications, it's important to state, because there are some medications that you may be taking for a medical condition that may not be okay during pregnancy. For example, a woman who has a thyroid disease and is taking some anti-thyroid medication, we need to be aware. Or a woman who is having seizures, who is epileptic, and is taking some medications to control epilepsy, and we don't know that you are on these medications. Or even the more common one, the woman who is hypertensive, and you are taking medications, lisinopril, amlodipine. Those medications are not safe in pregnancy. So we would convert you to a safer medication, and then you continue. Of course, for those who went through IVF, we would have done all of this even before you get to the stage of booking for antenatal. Because once you're set to do your transfer, that is when we need to review your medications and place you on the safer one. Okay? And so we take you through all of these, and then we do your examination, detailed physical examination, just to be sure that everything is fine. Please, talking about physical examination, for all our pregnant women, during the course of your antenatal, please, let's examine your breast. Let's check your nipples to be sure that your nipples are okay and they are ready for breastfeeding. It's not when you have delivered, we now realize that you have an inverted nipple. Instead of it pointing out like this, the thing has gone inside. If we don't know on time, baby will not be able to establish lactation early, because we now have to now start bringing it out. And that process can take time. But if we know before, during the antenatal, you can begin to pull it out gradually yourself. Okay? So that by the time you are set, by the time you deliver, everything will be fine. Okay? So the physical examination is important to pick that out. And then, of course, you would we'll do an ultrasound scan for you to see how the baby is doing. Usually, by the time we're doing this scan, for those who are registering for antenatal, you would have had some other scans done before, during. I'm talking about those, for our patients who are doing their antenatal with us, this won't be your first scan. You'd have had scan done during your your luteal support, okay? But the scans we do during your antenatal care is to see how your baby is doing. Check the well-being to ensure the baby is growing. And so we'll use different parameters, the biparietal diameter, or the femoral length, or the crown rod length, depending on the age of the pregnancy, to determine if your baby is doing well. Okay? And then you do your blood test, your medications, and then you book appointment for the next test. For your next visit, the test. So the routine tests that are done is what is up there: full blood count, that checks your PCV, white blood cells, and platelets, your blood group, your genotype, and then serology, hepatitis B and C, syphilis, and HIV. But most of these tests already would have been done by the time you are booking for your antenatal. So a lot of times we don't repeat these tests. So the other antenatal test that we may do, next slide, like I mentioned before, is the Combs test, and that is if your restos negative, or the fasting blood sugar. If we discover that there's glucose in your urine, then we'll ask you to do a fasting at 2 hours. And then the group B streptococcus is done around the 35, 36 weeks for patients who are at risk of developing this. We don't do this routinely, but I know that abroad it's a routine for them, because some of our patients who want to go and deliver there is part of what is required for them to do. Okay. Now, next slide. So you do that. Those tests are done during your first visit, during the booking visit. Then when you are 28 weeks, you are expected to repeat your PCV. So if you are 28 weeks and that has not been done, please make sure you remind your doctor to do your PCV. PCV means packed cell volume. Is to check your blood level, the oxygen carrying capacity. And then, of course, you will do your fasting blood sugar in 2 hours. Now, why this is done routinely for us here is because at this age of pregnancy, you are required to do your fetal lung maturation. What is fetal lung maturation? The fetal lung maturation is a process that is done using medications, particularly steroids, to facilitate the maturation of the lungs of your babies. And the reason why we do this prophylactically, meaning that there's no problem. We just want to do it just in case the baby decides to come out early. If a baby is delivered at 30 weeks, The baby who has had a fetal lung maturation will have a better chance of survival than the baby who has not had a fetal lung maturation, because the lungs would have developed faster if the patient had steroids. So you come in for 2 days, you have that done, and then you go home. Then after the 2 weeks again, you repeat your PCV, and then after the 6 weeks, you repeat the PCV. So we just want to check and be sure that your PCV is fine. Okay? Your PCV is fine. For obstetric scan, for us here, we do your scan every time you come to visit us. It's okay, no problem. We have the scan machine. We are happy to provide you with that service to make you happy. At least when you hear your baby's heartbeat, tiki, 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 you smile. I say, hey, I'm okay now. My baby is fine. And then you go home happy. All right? But the scan that we do at the different stages, the first scan that is done is to determine, and for us here, most of the first scans are done after you are confirmed pregnant. 2 weeks after you are confirmed pregnant is to determine the location, the number, and the viability of the pregnancy. And thereafter, you continue to do your 2 weekly scan just to see how the baby is doing. All right. At 16 to 20 weeks, we do what we call an anomaly scan, where you check detailed scan. We don't do this one. Let me just say, this anomaly scan is usually a very detailed, thorough scan. You can spend up to 1 hour on the table, just to be checking and be seeing whether you check your brain, check the score, does the baby have any abnormality. This one is done by a specialist in ultrasonography. All right. What we do is the normal, regular obstetric scan. The question you want to ask me, doctor, why are you not doing it? Is it not important? Well, we're not doing it right now. And if I look back at our practice, I ask myself, if we do it, what is the advantage? We are not doing it, but we are doing the general obstetric scan. What is the disadvantage? Truth be said, there's really no advantage, all right, of doing it, or rather, there's no disadvantage of not doing it. But the one that we're going to start introducing very soon, which I know you will all love, is the 4D scan. And when we do the 4D scan, we can also introduce the anomaly scan too. The 4D scan is to see your baby real, life, like the way it is inside your body, like picture. I can see shaking her head. Hey, that one is okay, but know that terms and conditions will apply to come at an additional cost. You know now. All right, but we will give you a very good picture of your baby, not 2D, because the one you have been seeing is 2D. And some of you need eye of faith to see the baby very well. Say, let me see the head. Where's the head? Okay, that's the head there. What of the face? Okay, this is the face. Okay, what about the bones, the leg? Well, sure, I just agree with me. Why inside you say, so even if they know that I don't know what I'm talking about. But when you do the 4D scan, you're able to give a picture of how the baby looks inside. And I think it's something that it would be nice for you to show your baby that this was the way you were looking when you were inside me. All right. So from next year, we're going to start offering that service, and we'll tell you at what age of pregnancy that will be done. Okay? Next. So the schedules, normal schedules for your antenatal visits. Usually we do 3 to 4 weeks, although we don't do this one here. Our patients like to see us more frequently, and we don't mind. So we see you more frequently. We see you every 2 weeks until you are 36 weeks, and then after that we see you weekly. All right, but generally, what is advocated is 3 to 4 weeks. 4 weeks for low risk. If there's any reason why we should see you more frequently, then we can reduce the number of times, or rather increase the number of times that we see you. Okay. Next slide. So just for purpose of emphasis, what must be done at each ANC visit? The first thing is what? Do your vital signs. Very important. That is the very first thing that must be done. And then after that, you have an interaction with your doctor or nurse. The purpose of that interaction is to just give you an opportunity to be able to discuss some few observations or queries or worries with your doctor. Oh, I felt this one. Oh, the last 2 weeks, this was how I was feeling. Or, oh, I don't have any problem at all. All right. So interacting with your doctor. And first year, when you see your doctor and the nurse, they do your scan, and they further reconfirm that you are fine. Your baby is doing fine. So we check you, and then we check the baby, and then we may or may not send you to the lab for test, depending on what you complain about. And then you pick up your medications, and then you book your next appointment. All right. So that's basically what your antenatal visit should entail. Next slide. I just put here the routine medications that you are on, like I said before. So these are the things that most of you are on. That pregnant care of ferritin, anti-malaria, vasopressor, salbutamol, clovina, and then, of course, tetanus toxoid injection. All of you must have at least 2 doses of tetanus toxoid injection to be able to prevent the baby from getting tetanus infection. All right. Although these days, based on how we care and where you take your delivery, I honestly feel that tetanus injection is not really that important. But the only reason why we have not changed is because still a lot of our women in Nigeria still deliver in unwholesome environments. Some deliver at home, some deliver in the farm, some deliver in some places that are not so hygienic. And that is why it's a national policy that has still continued to be in place. Okay? So even for us here, women who deliver here with us, we still have to give it no harm. And then you continue with your visit, and then you prepare for delivery. So we now usually start counting down. For women who got pregnant through IVF, after you have done your fetal lung maturation is when we actually begin to count down. Okay? Because you have not entered into your 3rd trimester. You're not looking forward towards delivery. When will that day come? When will that day come? But the main countdown starts from 36 weeks. At that time, you have about 1 to 2 weeks to go. So you begin to count down. You want to be sure that you are ready. You have bought all your baby things. You have a list given to you from us. And you have bought them. If possible, you have packed your bag. No, if you have not packed and you have to come to hospital, confusion. You will carry one leg of this thing and leave the other one at home. Because you will not be coordinated. So we advise women to ensure that you prepare early. Don't wait until the last minute to go shopping. Or guys in the house, please help in this regard. Unfortunately, it's only one Oga that is here. The other guys are not here. Let's help in this regard. Prepare. The good thing about this thing is that the baby gives us 9 months notice to prepare. So one will say, I was just waiting that, okay, by this time is when, Don't wait till that time. I'm sure by the time you're already 28 weeks, most times you already would have been aware of the sex of your baby. So if you want to buy sex-specific clothing, you will know. Okay, I'm going to deliver a male, I'm going to deliver a female, or it's a boy and girl. And then you buy, if you don't, for some reasons you don't know, and then buy the unisex. Buy the one that baby will use for 1 week or 2 weeks. After baby is born, say you will not know what the sex is. Then you cannot begin to buy other ones. All right? So make sure you get ready. And that is when we also begin to get ready for you. For most of our patients who get pregnant through IVF, we usually like to have you delivered. We usually like to have your delivery programmed. We like to have you delivered by cesarean section. Is it that we can't deliver by natural means? Yes, you can, but don't want to take that risk, that long, sometimes undetermined process. And anyways, most of the women who get pregnant, who come through IVF, if you look at their history, most of them qualify to be delivered by cesarean section. And so we want to just book your delivery. So what will happen that once you're 36 weeks, we would give you a date. Any patient, once you get to 36 weeks and you're delivering here, we will give you a date. We will discuss what date would you want us to deliver you. We normally aim to get you to 38 weeks. 38 weeks. But really, from 37 weeks and above is fine. Because 37 weeks is 37 completed weeks is 10. But we want to say, okay, let's get to 38 weeks. Let's maybe gain some extra weight, maybe be full time. Some people in other centers, other parts of the world will wait till even 39, 40, even if you're going to be delivered by cesarean section. All right, but we do 38 weeks. But if we look at the woman, this woman, she has tried. Kai, she's using her last strength. We may decide to do it at 37 weeks or even less, particularly if you are carrying more than one. For a woman who is carrying 3 and you have gone beyond 34 weeks, I will be hailing you. And if you tell me that, MD, I'm tired, I don't try. I am tired. I'll say yes. I look at you, I'll bring you in, and I'll deliver you. Once you are above 34 weeks. Once you can get to 36 weeks, wonderful. Because babies delivered at 36 weeks and above, not likely babies will spend any time in the neonatal. They'll do very well. All right? But 34 weeks we expect about 34 weeks, babies would have achieved full lung maturation. However, some babies may delay, particularly for patients who are diabetic. There may be a slight delay in the maturation of their lungs. So we usually want to extend, but 38 weeks is good. So singleton, twins, 38 weeks is fine, is what we aim for. For triplet pregnancy, once you get to 36 weeks, that will be fine with us. Okay? Of course, if you're going to be delivering spontaneously, we will await you to come in in spontaneous labor. If that doesn't happen by 42 weeks, then we'll have to induce labor. Okay? As if there are no contraindication to a vaginal delivery. All right? Next. So we also expect that, next. We're still talking about the preparation for delivery. We expect that at 36 weeks, if you're delivering here, you'd have made your deposit for delivery. You should have gotten your delivery item, the list, so that you can get all the things you need to get. At that time, you would have done your last blood work, your blood test, your PCV at 36 weeks. And if you get to 38 weeks, a day or two before your delivery, you will come in to have your blood work done. But we need to have your current PCV, but we'll do a full blood count. we'll get blood ready for you just in case. No, hemorrhage is the commonest cause of maternal mortality. Sometimes we don't know women who will spring surprises. A lot of women don't end up being transfused, but we must get blood ready for you and cross-match. All right? Now, for some women, particularly those who are going to be delivering via per vagina, there are some exercises that they'll be told to do. All right, so that will help in the delivery process. But of course, exercise during pregnancy, we would have that one as a lecture during the course of these antenatal classes. So that one will tell you what are safe exercises that you can engage in, that you can do, that will be of benefit to you. Okay, so everything will go well with your delivery. Once, for most patients who are coming in for delivery, you are admitted a day before the date of surgery, because you need to come in so that we can have the preparations. The nurses will prepare you and then check your vitals. You would have done your blood work. If that has not been done, on the day you come in for admission, the blood work is done, but usually we prefer to have that done like 2 days before you come in. All right? And then you come in, examine you, ensure that everything is fine. And then the next day, your delivery is effected. Usually the postnatal care is very uneventful. Usually for most of our patients who deliver by cesarean section, 3 to 5 days afterwards, they are back home with their babies. Fine, no challenges, and we expect them to come in for checkup either 2 weeks after or 6 weeks after, depending on if there are any peculiarity. For a woman who has a blood pressure issue, we want to see you more frequently. So rather than give a 6 weeks appointment, we'll give you a 2 weeks appointment to come in so that you can have your blood pressure checked and be sure that everything is going on well. Of course, before we discharge you, we want to make sure that you have established lactation, that baby is feeding well. All right? And before you are discharged, the baby must have had his first immunizations. All right? And thereafter, you'll be told the routine for immunization. And then, of course, for those who got pregnant spontaneously, after 6 weeks, when you come for your postnatal checkup, we will discuss contraception. When do you want to have your next pregnancy and what we are going to use to prevent you from getting pregnant soon. But for those who got pregnant through IVF, where there was already a challenge, contraception does not come in. Door has been opened. You want to close it. Haba. They say, doctor, please, door has opened. Now let it be opened. I want to have as many. I started late. Let me catch up. Meaning that we don't discuss contraception for most of our patients, considering the fact that they got pregnant through IVF. Okay. So when you come in for your postnatal checkup, we want to check your physical well-being. How are you coping? Now you've been with the baby. Are you getting enough support? Are you sleeping well? How are your vital signs? How is your psychological state? Are you still bleeding? We just do all of those general checkups just to be sure you are okay. Like I said before, a woman is still considered pregnant until when? 6 weeks after delivery. That's if you carried one. If it's 2 or 3, just extend it. Okay? So we want to follow you up to be sure that you are okay. All right. So lastly, the antenatal classes, it's just to further reiterate, it's an opportunity for education, the platform for education, opportunity for interaction among our clients. You know, you'll say, okay, I saw you doing that antenatal class, so how far are you doing? There are some people who have become very close friends, so they didn't meet anywhere before, it was here they met. In fact, some of them, it was during embryo transfer. In fact, the kind of bonding that takes place during that embryo transfer is not a joke. After that transfer, you see them calling themselves, oh, your test, I was pregnant. Me too, I was pregnant too. Hey, And then they just continue. They just keep on. You know, women who did transfer on the same day, they're likely to deliver, but they like to do everything on the same day. They will come for their circlage the same day, so they will still meet. They will start their antenatal on the same day. If they decide they want to be coming on this particular day, they'll be seeing themselves every 2 weeks. And then they will likely also want to deliver on the same day. And then they just become friends for life. All right? And so it's a very good platform for interactions. All right, so no, it's not every 2 weeks we hold this antenatal class. By popular consensus, people agreed we should be having it every month. Abi? Once a month, at least for now. So it is once a month, and this is where it holds, okay? So just give us some terms and conditions for those of us who may not be aware, so that you would be properly, So the package that you are on, for those, I want to be sure everybody has paid for antenatal. If you have not paid, please visit the accountant as soon as possible, okay? And do the needful. So our package still remains $250. We are trusting God that things will be better next year. So there'll be no cost for any review. All right, but still $250. That covers all your care from when you got pregnant up until delivery and postnatal. That includes your scan sessions, your medications, and then your classes. What is not included in this is your 4D scan, or if you need to do a non-stress test using the CTG machine. All right? And then other tests that are done that are not routine. For example, you're sick, you're having malaria, typhoid, and we did a test for you and treated you. You need to pay for the test that was done, and then for the additional medication that was given. Okay, next. So I just said it does not include medications, okay? It also does not include your admissions into, if you need to be admitted for any reason. During the course of the antenatal, you need to pay for the admission and then for the care that is given. Also to state that it does not include your delivery. Some patients will still ask me, and this 50, say it doesn't include my delivery. How can it include your delivery? It doesn't include your delivery, so just black and white. So for those who probably may not be able to make payments at once, we offer 2 instrumental payments. So you can make the first one and then you balance up later. Okay, I think I need to round up now because they're calling me for transfer. Okay, so next slide. These are just the cost for delivery. This is vaginal delivery. Next slide. These are for vaginal delivery where you have episiotomy, perineal tear, all of those other things. Neonatal intensive care, resuscitation, and all of that. And then cost for cesarean section. All right. Now it depends on if it's an elective or emergency, or if it's first surgery, or if you had a previous scar. All have different rates. Next. Pediatric fees, again, depends on what is done, and the cost of the resuscitation depends on whether it's a preterm baby that is being resuscitated, or if it's a term baby. All right, next. Thank you very much. Okay, so time for questions. Any questions, any comments? Those online, if you have any question, please, you can also just indicate and ask your question. Okay, there's a question in-house. Sit down. Could be an issue. Oh, very good question. Now, for those patients who are already overweight or obese before you got pregnant, don't start losing weight to say, oh, they said my weight should not do this. Like I said before, what we're looking at is not what your weight is when you're pregnant, but how much weight you gain while you are pregnant. So we usually don't want patients to start losing weight. So they're not eating because they want to lose weight. Just eat healthily. Do you understand? If you gain enough weight, no problem. All right. After you have delivered, you try and lose the weight. As long as you're eating healthily and you're having a steady weight gain, there's no problem. Even if you started with a weight above 90 before you got pregnant, it's still not a problem. It's just that we need to know what you started with and be able to determine how much weight you're not gaining. Okay? Okay? Okay. 6 weeks. Where you tie your womb, you use a gedu. Well, after CS, we don't usually recommend that you start using gedu immediately. You understand? You know, women's tummy and what happens after delivery differs. There's some people who, after going through a delivery process, even if it is vaginal birth or cesarean section, their abdominal wall becomes so lax. Their tummy, actually would, their uterus and all of those things. So using the gedu sometimes will help you when you are exercising, but you still need to exercise. And so it just to help as a form of support. But we don't encourage using gedu 1 week after you have delivered, if it's a cesarean section. The pain will be just too much. And there's no need to go through that discomfort or in a bit to say, oh, my tummy must be flat. No, what makes your tummy flat is exercise, and which will come later on. And then gradually you will get back to size. Okay. Okay, I have some questions here. What is expected by a patient for cervical cerclage? So what is expected is that once you have completed your luteal support, then you'll be scheduled for your cervical cerclage. All right, and once you've done your cervical cerclage, you spend the night in the hospital. You do it today, you're discharged tomorrow, and thereafter you come, you are seen for 1 week, after 1 week for follow-up. At that visit, then you can now register for antenatal if you're doing your antenatal with us. All right? That was the second question. Okay, it was just one question. Okay.
What week does that trimester start?
Exactly. At what?
Third trimester starts.
Third trimester starts at 28 weeks. Or rather, from 26 weeks and above. First trimester is 13 weeks. Second trimester is 26 weeks. And after 26 weeks, the third trimester starts. Can you unmute your mic and talk directly to the doctor? Okay. Okay, so they don't say that one. Okay. So we have answered the question. Any question from the house here? Yes. Okay, that one is not part of this this thing. We will still come to that class. Alarm bells, what we call alarm bells, the things that we will see that will make you call and speak to a doctor or to a nurse. And there are some things you experience that will just, it's normal, no problem. All right. Another question? No? Okay, so I want to say thank you very much for coming for this antenatal class. I want to believe that we have been educated We have been properly informed. And our next antenatal class will be 2023. Okay, God willing. And so on behalf of the management, I want to wish every one of you a Merry Christmas and a prosperous 2023. And we will all see in the new year. But of course, we'll be seeing during the antenatal clinic visits. So that one will still continue, but our classes will begin next year, January. The date will be communicated to us. All right? Thank you very much. I need to go now for transfer. They just gave me a call. Have a wonderful weekend. Yeah. Yes.